Good morning, everyone. I would like to welcome you all on the second day of our seat-free course. Thank you once again for a wonderful discussion yesterday, and we are looking forward to new interesting presentations. And we are starting from the next form of diabetes that requires the differential diagnosis, and where the diagnosis is crucial for the proper clinical care management. And it is my pleasure to co-chair this first morning session together with Professor Mlynarski from Łódź Medical School. And it is even a bigger pleasure to introduce Wojtek to present the first lecture. Professor Mlynarski will be talking about permanent neonatal diabetes, new clinical syndromes, new scientific insights. Wojtek, the stage is yours.
So first of all, I would like to thank Maciek for giving me this opportunity to share with all of you some interesting findings and some clinical hints for treatment and management of neonatal diabetes. From the very beginning, all the patients with pediatric patients were classified as type 1 diabetic patients. But for some cases, this scenario is not true. And everything started from this epidemiological approach when they found that there is slight increase in frequency of neonatal diabetes with diabetes onset within the first 6 months of age. And after that, there is a nadir and another increase in frequency of this diabetes. And this is the first evidence that probably this period from birth to 6 months of age is completely different diabetes. And there are another evidences that this type of diabetes has completely different genetic background. So these patients have similar HLA susceptibility to type 1 diabetes alleles frequency like healthy individuals, but not like adult type 1 diabetic patients, similarly to other type 1 diabetic patients who are diagnosed in advance to 6 months of age. What we can say about neonatal diabetes and the definition of this. This is a diabetes diagnosed before 6 months of age, or sometimes we can say that this is diabetes diagnosed before 12 months of age. This age of diagnosis is very important from clinical point of view, because we know that most of cases with potassium channel mutation are diagnosed before 6 months of age, only a few between 6 and 9, and almost none after 9 months of age. From another perspective, we know that this type of diabetes is very rare in all European populations, and one can suggest that this type of diabetes is not polygenic like regular type 1 diabetes, but this is monogenic type of diabetes. And we put right now this diabetes into third type of diabetes as a other specific type. Most of these cases suffer from monogenic diabetes, which is caused by mutation in many of genes which are somehow related to beta cell function. So, as I said, there are plenty of different types of neonatal diabetes and plenty of causes of this diabetes. But the most important is the first one, This type accounting for about 50% of all neonatal cases, and this type of diabetes has very severe consequences from clinical point of view. Everything started from this paper from Anna Gloin. In this paper, they discovered that in normal situation, beta cell function is related to potassium channel, which is activated in the fasting state, but in after meal there's increase in glucose production and increased glucose level, and after that also the metabolism of beta cell is increased, and there's a high concentration of ATP in the beta cell, and this potassium channel is closed. So this is related to the polarization of the membrane and the influx of calcium ions, and finally insulin secretion. Among patients with neonatal diabetes, according to Anna Gloin paper, there's a defect related to this potassium channel. So this potassium channel is resistant to high concentration of ATP. So in this case, there is hyperpolarization of the membrane, no calcium ion influx, and no insulin secretion. We can measure this ion current using the patch clamping. So in wild type, in normal conditions, we can close this potassium channel in vitro using some of the concentration of ATP. Unfortunately, among the patients with neonatal diabetes, this ATP can't close the potassium channel, and the current is still present, as you see here. But fortunately, we have one very old drug on the market, the group of drugs, sulfonylureas, and we can block this potassium channel with sulfonylurea drugs and restore beta cell function and restore insulin secretion. And after this switch from insulin therapy to sulfonylureas, you can observe very often this very nice view from the patient's glucose meter. What kind of phenotype are related to mutation in potassium channel? There are plenty of different phenotypes. One is transient neonatal diabetes, which dissolves within a few months after onset. There is a pure neonatal diabetes with permanent phenotype, but we can also observe in some cases some developmental delay together with diabetes and sometimes epilepsy. So we can call this syndrome as a DENT or IDENT. Looking at the functional studies, we all know that severity of the symptoms are related to severity of the mutation or resistance to ATP or susceptibility to ATP of the blockage with the beta cell potassium channel. And as you see, if we have transient or normal individuals, the potassium channel fractional current is almost closed by ATP, but among the patients with IDENT and DENT, there's a severe resistance to this concentration of ATP. And as you see here, the response and the current is present. But the issue is that some of the cases have completely different in vitro phenotype and also in vivo phenotype, and we can treat only some of these individuals. What does it mean, mild phenotype? We can say that mild phenotype is related to transient or just permanent neonatal diabetes caused by potassium channel mutation, and in almost all cases we can treat these patients efficiently using sulfonylureas. However, if we look at the Polish cohort, we have 3 families with potassium channel mutation. In all cases, this mutation was very mild in phenotypically characteristics in the proband and also in vitro studies. Interestingly, we found a real pattern of MODY. So we have in all probands, we have neonatal diabetes, caused them different mutation in potassium channel, but we found that also fathers suffered from diabetes, but the diabetes was diagnosed not in neonatal stage, but in later in the life, or was just accidentally diagnosed after glucose measurement in this individual. So we can say that there are even more complicated story behind this potassium channel mutation. So we can have transient neonatal diabetes, we can have neonatal, permanent neonatal diabetes, we can have ident or dent phenotype, but in some very unusual cases we can have real MODY phenotype, so it means that this is kind of MODY, I don't know, Alessandro, 12 or 13 or something like that. So we need to keep in mind that even among the patients who inherited diabetes and was diagnosed after 6 months of age, we are not able to completely exclude neonatal diabetes caused by potassium channel mutation, but this is a really unusual case. Let me go to another example of neonatal diabetes caused by proinsulin gene mutation. This mutation is a kind of new old track, because everybody started thinking about diabetes from 1921, from this discovery of insulin, but nobody focused on the gene of proinsulin as a cause of diabetes. And right now we know that there are a few people in the world who are the carriers of the mutation in the proinsulin gene, and this mutation can cause ER stress within the beta cell, and finally beta cell damage and apoptosis related to this overwork ER. Interestingly, from our studies, we found that there is some pattern in the inheritance of this disease, that if we have the inheritant allele coming from the father, all the patients are diagnosed before 2 months of age. But if we consider the allele which came from the mother, the onset can be at the older age, not only in neonatal cases.